Dr. Momina Motiwala, and I have done my FCPS training from Aga Khan University Hospital, and Dr. Robia Ghafoor was my supervisor, and we did this research together along with Dr. Sheikh Bilal Badar. Dr. Bilal Badar is currently in Canada, and so both of us, me and Dr. Robia, are here so we can answer your questions.
Thank you very much, Momina, for joining us and for accepting our invitation. And I'm going to ask Dr. Ghafoor to give us some introduction. Dr. Robia Ghafoor, please.
Dr. Momina is my resident. She has done residency under my supervision, and this was her project, and she has done a really good job being a junior resident, and she took the challenge to work with the patients, and she collect the data in the form of randomized clinical trial. That was a great thing to learn for her. And that's why I request her to take the lead, and she's the first author of this article.
Professor Nekofar?
Disconnected for some reason. I'm back now. Sorry about that. Professor Ghafoor, please go ahead and repeat again.
Okay, and this project basically is started by Dr. Momina Motiwala, being a second-year resident. And with
Professor Ghafoor, can you talk a bit closer to the laptop or louder, please? Thank you.
Okay, can you hear me clear?
Yes, much better, much better.
Okay. Dr. Momina is basically my resident, and during her residency, she has taken the this project, and she has completed it, and she has collected the data among the residents with her colleague resident from the patients who are coming to the clinical area. And then she has done a really good job basically, and then she has done the write-up. So that's why I will ask her to basically present this project, so she can learn a lot of things regarding the basically critique that anyone from the expert panelists can give her for the future projects.
Okay, thank you very much for joining us, accepting our invitation. We are very happy to talk about your publication. But please give us also an introduction about yourself and your colleagues and your university and your department as well.
I'm Dr. Robia Ghafoor, and working as an endodontist and the operative dentist. And I have completed my residency almost 10 to 12 years back. And then later on, I have joined as an assistant professor. And I'm working as a supervisor and the director of the residency program previously. And now I'm taking residents under my supervision, and all the residents are doing a really good job. And my basically work is to supervise them in their clinical areas. And right now we have 8 residents, and we have 3 supervisors in the Aga Khan University hospitals. And all the residents are doing really good job, and they are basically doing the basic to advanced level of resident research, and then later on they are trying to publish in a good reputable channels. So this is one of the basically example of a resident project that has been published, and today I will basically accompany her for the discussion of this article.
Thank you very much.
Basically the Sheikh Badar, and he has completed his residency now, and he's working in Canada. So
oh, nice, that's great. And I think Sheikh also connected, I believe he is connected, but now I think he's disconnected again. Okay. So when he comes back, I will ask him to start talking as well. But I'm honored to say that we have Professor Sanjay Miglani, the Dean of the Educational Committee of Asian Pacific Endodontic Confederation, APEC, and also Professor Hussein Al-Hawaizi, the President of Iraqi Association of Endodontists, Professor Baber Kayahan, the President of Turkish Endodontic Society, and the ex-President of Asian Pacific Endodontic Confederation. Professor Sanjay Miglani, please officially start the session, the 17th online journal club of Asian Pacific Endodontic Confederation, run by Tehran University of Medical Sciences. Professor Sanjay Miglani.
Thank you, Dr. Nikofar. I hope you can hear me well.
Very well.
Thank you so much. It is my pleasure to welcome you all, and a big thank you to Dr. Nikofar, who makes sure that we meet again and again, and we have some brainstorming session. And my special welcome to the Pakistani team. They are our neighbors and very close friends, and I wish them all the success and all the best wishes for this program. Thank you.
Thank you very much. Professor Baber Kahan, please.
Hi, can you hear me?
Yes, very well.
Yeah. Thank you very much for this organization, a great scientific night again. I'm very happy to see all my friends again, and thank you for choosing this subject, because carcinogenicity is always an important issue in endodontics. How to use it, when to use it, how to remove it. Thank you very much for everything, and please, thank you.
Okay, thank you, Barbara. Thank you very much for your support. Professor Al-Hawaizi, the president of Iraqi Association of Endodontists, please.
Well, good evening in Iraq, or I must say good afternoon or whatever. Thank you very much, Dr. Nikofar, for another session. Really, I finished my clinic very quickly and came home just to be. I'm very eager to be with my colleagues, and I really thank you very much for this topic. Really, it's a clinical topic, and I would like to see what the discussion will end up with this important issue. Thank you very much.
Thank you all. Thanks for introduction, and for authors to know that we have also Professor Sagib Habib from Pakistan, and he is actually one of the very good appraisers. So it makes your life a bit difficult now because he is with us as well. We have Professor Munsef from Mashhad University as well, one of the pioneers of endodontics in Iran. So we have a very good participants tonight. So from now, I'm going to be a bit harsh with authors. Obviously, we are going to have a lot of questions, and we don't hesitate to say that why you did this, why you did that, and you need to give us some explanation. The reason of this discussion is to learn more, not to just be harsh or say something. So I'm just joking, and I'm just making you ready for the questions that one of my very good colleagues, Associate Professor Hadi Asadian from Tehran University of Medical Sciences, is going to tell us an abstract from your article first, and then he is going to critically appraise and methodically going through all the methodology, results, discussion parts of your article, as usual we did so far. Professor Hadi Asadian, please go ahead, introduce yourself, and start the session.
Hello, thank you very much for your kind introduction. My name is Dr. Hadi Asadian, and I'm honored to be a Professor Nikofar's colleague in Tehran University of Medical Sciences in Department of Endodontics in School of Dentistry. Tonight, it's a great pleasure for me to be with these great names, actually, to appraise this article, and I think that we have a good time with each other. And of course, it's a great pleasure for me to be with you all. So let me share my screen if.
Yes, please go ahead, because yes, we can see now your screen.
Okay, let me minimize this. Okay. All right. The title of the article, which is going to be appraised tonight, is comparison of two different methods in the removal of oil-based calcium hydroxide from root canal system, a triple-blinded randomized clinical trial. Okay. First of all, let's go through the abstract of this article. This study has compared use of rotary master apical file, or RMAF, and ultrasonic activation of a hand endodontic file in removal of silicone oil-based calcium hydroxide from the root canal. So the methodology consists of 60 cases with necrotic pulps, and the authors have used periapical radiographs in order to evaluate the removal of calcium hydroxide from the root canal system, and also the interval which was determined was 7 days, before insertion and after elimination. The 7 days period was considered by the authors, and a scale from 0 to 4 was considered by the authors, from so that the scale of 0 and 1 were effective elimination, and score of 2 and 3 were ineffective elimination of calcium hydroxide from the root canal. And the results showed that there was no statistically significant difference in removal of calcium hydroxide in any of the groups, the rotary or ultrasonics, and both techniques were equally effective in cleaning all thirds of the canal. So in conclusion, it was stated that none of these techniques were able to completely remove the calcium hydroxide from the canal, and there was not statistically significant difference between the arches. The location of the teeth were not statistically significant. Therefore, there was no difference between maxillary mandibular teeth in removing calcium hydroxide. So this is the abstract of the work, which is going to be discussed in more detail in some minutes. So if you're ready, we can go through the introduction portion. Is it okay with you? Is it okay with you, Professor Nicophar? Is it all right?
If you go back, Hadi, please, to the abstract.
Yeah.
If there is any question, please, you can electronically raise your hand, any of the participants, and ask their questions. While we are waiting for that, I have actually a question, which is about the importance of the use of calcium hydroxide inside the root canal system between the clinical session. Is it really clinically important to use this intracanal medication, particularly when we have the result of your study, or we go back to the result, obviously, but in your conclusion, you show that it is very difficult to remove calcium hydroxide from the canal. So it must worth it to use Metapex or any of the calcium hydroxide paste inside the canal as an intracanal dressing between the appointments. My question is it really important to do that, or can we just leave the canal open or do the root canal treatment in one session? What was the reason of the use of calcium hydroxide?
So we took specifically necrotic cases with chronic apical periodontitis. So such cases have resistant bacteria, especially in the lateral canals, and irregularities, which is not accessible to the cleaning and shaping instruments that we use. So such medicaments, when placed inside the canal, may help in disinfecting those canals efficiently, so that when we go towards the obturation, the canal is sufficiently disinfected and clean from these bacteria, because E. faecalis is one of the most common bacteria which results in root canal failures, and which we find in the pre-treatment cases. And when you talk about because it is difficult to remove, so there are other formulations of calcium hydroxide available as well. In this one, it had silicone oil. That is why it was difficult to remove, and that is, but it is used because it is, according to some studies, silicone oil and iodoform is responsible for better removal of the E. faecalis bacteria. Otherwise, we also have calcium hydroxide with saline, which is easily removable, and it is not oil-based. And other than calcium hydroxide, we also have a number of intracanal medicaments. It can be chlorhexidine or a few others, or a combination of two. So this study was focused on oil-based calcium hydroxide.
Sorry. In that case,
Okay.
I think you are trying to say that if a clinician decides to use calcium hydroxide, then your study will be started. Otherwise, these days we know that even in necrotic teeth with apical periodontitis, we don't have any problem to do the root canal treatment in one visit. So therefore, if we decide to do that in one visit, we don't have any problem like leaving calcium hydroxide inside the canal. Yes. So assuming that it is important to use calcium hydroxide for any reason, then your study has some point to do and to show some results as well. Okay, thank you very much. There is a question from Professor Sanjay Miglani about the methodology, and Professor Asadian said that he's going to mention such a things in M&M material methods part. So is there any general questions? Is there any other comments, any general comments from anybody? Okay, Hadi, please go ahead.
Yes, of course, I've got a lot of points, but I want to just go through these points in their specific parts, and let me just go through.
Okay, yeah, I think Professor Farhan Reza Khan will have a question. Professor Farhan, please go ahead and ask your question.
Thank you for giving me the opportunity. Hope you are well. I've just got free from clinic, so I'm still in car. So I took the opportunity of asking questions.
Thank you very much for joining us in this situation. Thank you very much. That's a pleasure. Please go ahead.
Thank you. So I've noticed that although this study was done in my center, and I know the investigators and all, it was very well done and all. However, I've noticed that the issue in the study is about the sample size. When we calculate sample size, the sample size that we calculate is for individual study group. For example, if we have calculated a sample size of 42, it means that 42 participants or teeth per group. But here, what we have done, that the numbers were actually divided into two groups. So as a result, the power of the study has decreased. So study is technically underpowered in terms of detecting a difference. So as a result, if there is a difference between the groups with small numbers, we may not be able to detect that difference. So whenever we calculate sample size, it's imperative that we multiply it by number of groups rather than dividing it by number of groups. So that's the first limitation. The second limitation is about selection of the statistical test. Here, we have used Mann-Whitney U-test, which is used for ordinal data for comparing two groups. But here it's not only two groups, but three layers, for example, middle, coronal, and apical. So whenever we are using such ordinal data in two layers, so the most appropriate test is Friedman test rather than Mann-Whitney. So that's the second thing. So if we were to do it again, we would rather use a Friedman test, which is a non-parametric variant of an ANOVA. And the third limitation that I have noticed, it's when we look at figure 4, the figure which shows the bars, so the error bar is missing in those bars. So whenever we report means or proportion, it's imperative that an error bar is given so that the dispersion of data is shown. Otherwise, just showing the mean or the proportion would not mean anything unless error bar is there. So I think these were the things that the editorial review or the reviewers probably have missed. So these were the three points that I wanted to share, and these were my 2 cents. Thank you, Dr.
Thank you very much. Thank you very much, Farhan. You always give us a lot of very, very just to the point comments. And this is also the comments that we have received in the chat box from Professor Sanjay Miglani in a form of a question. So we go back to that and ask the authors to discuss that in its own place. Hadi, please carry on. Thank you very much, Farhan.
Thank you.
All right. Let's get started from the introduction section. So in the introduction section, it is written that the objective of root canal the root canal treatment is to eliminate pain and infection from the root canal. And also it is written that the presence of bacteroids is correlated with clinical symptoms of affected teeth. One of my questions is that is it true to say that the most important and the most important aim of root canal treatment is to eliminate pain from the patient, even in patients with chronic apical periodontitis? They usually do not have pain unless they are symptomatic. So we have this kind of classification of symptomatic and asymptomatic apical periodontitis, which was not mentioned in this study. But I think this is important. I think it has to be mentioned that which type of apical periodontitis has been mentioned and has been taken into consideration in this study. And also, of course, this is a little bit harsh to start. I mean, as a starting point of the article, to say that elimination of pain is the main objective of the root canal system. So, is there any explanation about this very starting point of this study? What's your opinion?
So basically, it's just from the patient's point of view. Usually, patients come to our clinics because of pain. They do not, when in asymptomatic cases, they never approach a clinic that I don't have a pain, but I want to get a root canal treatment done. So it is from that aspect, if you see that the main cause is pain, to seek dental treatment for a patient. Other than that, yes, the objective basically is to debride the canal and to clean it from any sort of bacteria, because the infection is present.
Yeah,
so,
actually. But we are talking about a literal article. We are not talking about the patients right now.
And we have included the chronic apical periodontitis, the asymptomatic cases, that is mentioned in our inclusion criteria.
So, all right. And also there is another point in this sentence, the elimination.
But I think Hadi is right, Momina, because when we speak about the objective of root canal treatment, we need to be very careful about that.
Yeah.
The objective is larger area. So in terms of the main objective of root canal treatment, even it's not the saving just a tooth, it is saving the integrity of the masticatory system by saving a tooth. So it is much larger than just elimination of the pain. And sometimes the tooth is not painful, and we try to save it through the root canal treatment because we want to save the integrity of the masticatory system. I think this point is correct that Hadi raised.
Thank you very much. Also, another point to consider is this term bacteroids, because it's written, the elimination and control of microorganisms during endodontic treatment is important because of the presence of bacteroids is correlated with clinical symptoms. You know that bacteroids is an old-fashioned term. I just took it from Elsevier. Bacteroids is a genus of gram-negative, non-spore-forming obligate anaerobes, rod-shaped bacteria. So this group of bacteria are a small class of bacteria involving in odontogenic infections or endodontic infections. You know that endodontic infections are caused by a group of bacteria, so that bacteroids are a small group of those multi-species community. So I think that use of this term should be avoided, actually should have been avoided, let's say, because of the small portion to be targeted. What's your idea, Professor Nikufa?
So I think Dr. Nikofer is saying something.
Momina, Momina, you go first, please.
Okay, so yes, we here we went to basically address that multiple bacterial species. So we did not go into the literal meaning of bacteroids. So I agree with this point.
Okay, Dr. Farhan, please.
Yeah, just a small point. I think we are making a mistake here. Bacteroids and bacteroides. So that's a gram positive bacteria. The small they are called bacteroides, not bacteroids. So like they are like cousin member of Fusobacterium, right? So those are bacteroides, not bacteroids. However, I agree that bacteroid, the terms should not have been used, but those are bacteroides, not bacteroids. So there is a little, there is an addition of E there. So probably we are mixing the two things.
Okay, Hadi, please. What's your idea about the comment of Dr. Raza Khan?
I think they should have been written microorganisms in general. It was a better substitute for that. I mean, this bacteroid is something very specific. So there are a large number of other bacteria involving in the multi-species, multi-species community of bacteria residing in the root canal system, causing apical periodontitis. Therefore, it is necessary to remove all sorts of bacteria, not just the bacteroids. I mean, this is somehow misleading for the reader.
Mm-hmm. Yep, there's also a comment from Zainab Haji. She said microbes could be better word for that. Yeah, microorganism or microbes in general could be a better choice as well. I think Momina herself is also accepted the comment. Okay, let's carry on.
Okay. Okay, in the next paragraph, it is written that calcium hydroxide has been used as an intracanal ligament in necrotic teeth, in apexification, in apexogenesis after trauma to prevent resorption. And it has some effects like denaturing a potent endodoxin, which is called LPS or lipopolysaccharide, and its effect relies on its alkalinity. Yes, we all agree with that. And the next paragraph is written that in spite of the success of calcium hydroxide, there are some resistant microorganisms like Enterococcus faecalis and other species that resist against bacteria, resist against the action of calcium hydroxide because of their structural proton pump or other things that are important to resist. And therefore, Metapex was used. Of course, you know that Metapex is a Korean product, but here it is written Metadental Corporation from the United States. I don't know whether it is true or not. I don't know whether it's a joint product between United States and Korea or something that I don't know. Maybe it's not bad to be discussed about that. Of course, because of this resistance, the authors tried to use Metapex and to evaluate the removal of Metapex by these two systems. Metapex is a kind of oil-based calcium hydroxide, which contains 38% iodoform, which can aid in its antibacterial effect. And of course, it has a stronger antibacterial action against the resistant bacteria. So this was the reason why Metapex was used. What's your idea? Is it a Korean product or an American product?
Momina, the question is about the origin of the Metapex. As we know, Metadental Corporation is a Korean company. And you said that it is from USA. Do you have any explanation for that?
I picked it up from the packet that we had in our clinic. So now it's been a year, so I'll try to check if it's
okay. Thank you. And there is a comment or a question from Professor Miglani. Professor Miglani, please.
Yes. You know, calcium hydroxide has been very effective in primary endodontic cases. But if you want to justify it using an Enterococcus faecalis, for your kind information, calcium hydroxide doesn't work on Enterococcus faecalis. It has been proven beyond doubt. That's why people are working on different nanomaterials so that it works on Enterococcus faecalis. Calcium hydroxide does not work. So you cannot justify using calcium hydroxide just based on Enterococcus faecalis. Can I have a comment from you?
Okay, Momina, please.
So we went through a number of studies which proved that calcium hydroxide with iodoform had better, not as compared to other medicaments, but as compared to calcium hydroxide alone, it was better to use the Metapex formulation, which was the rationale of our study. Obviously, there are many more intracanal medicaments, and there are now even different mechanical instruments to, remove, and we might not need any medicament inside the canal for such cases. And this study was approximately done 1.5 to 2 years back. So then we thought it was rational enough to use Metapex.
No, you still did not answer my question. Does calcium hydroxide work on Enterococcus faecalis? It doesn't.
Yes, I have gone through studies, and I've mentioned the reference over here as well, which mentioned that E. faecalis, it was effective for E. faecalis as well.
I think you already mentioned that in the sentence, in the first sentence here, that Dr. Hadi already highlight that one, that it is actually resistant to complete eradication. You mentioned already that, and you said that maybe
used
adding
alone.
just iodoform. Yeah,
If
please.
used alone, if calcium hydroxide is used alone, then it is not effective for against the E. faecalis. But if it is used with some other vehicle or additive, then it will be better than calcium hydroxide alone.
Professor Miglani, do you agree with that? Adding iodoform can make it.
I'm sorry, I do not agree with that. So
yeah, still you
maybe,
think if we add iodoform to that, it is not going to work? Your idea is that?
Professor Miglani,
No.
I would like to. I would like
Yes,
to add
please.
something. Excuse me. I checked one of these references on the net, and I think it was this reference number 14. And it showed that in comparison with Metapex and use of calcium hydroxide with saline against eradication of, against Enterococcus faecalis, Metapex outperformed calcium hydroxide in comparison with, in combination with saline, okay? And this can be attributable to the presence of iodoform, not calcium hydroxide. And of course, you're true. That's I agree with you that way. But of course, the study is not about eradication of Enterococcus faecalis, so it's just an introductory phase.
Okay.
Yeah, so in general, I think we should say that we are not going to justify the use or not using calcium hydroxide in this type of cases. But for any reason, even if it is not correct, if a clinician decides to use calcium hydroxide, then this study have some place for that purpose. Yeah. So that is the idea. Thank you very much for the discussion. Very good discussion. Please go ahead, Hadi.
Yes. Okay, in the next paragraph, the main idea of this paragraph is about the remnants of intracanal medicaments. So it is stated that if intracanal medicaments remain in the root canal system, the quality of root canal decreases. I have a very big problem with this sentence. Decreased quality of root canal means what? Means diminished outcome, or let's say downgraded outcome of root canal treatment. If we have to say it that way, I think this cannot be a good scientific phrase for just elaborating such an idea. But I think the main idea of the authors refers to the presence of remaining intracanal medicaments and participation of the remaining intracanal medicaments in decreasing the outcome of root canal treatment. Am I right, authors?
Yes, you are.
But I think this structure should be changed, and I think this structure and these phrases are not explanatory enough. This was.
Excuse me, Hadi, do you mean if some remnant of intracanal medicament stays inside the canal, it's not going to have any effect on the outcome? Your idea is that?
No. I'm not saying that. I'm just talking about the structure of the sentence. That's all.
Okay.
And of course, this needs. It's a very nice question actually, because this question should be answered by clinical trials. But Another point that I have about this clinical trial is that this clinical trial does not answer such a question, which is a very important question. I mean, I believe that a clinical trial should answer my clinical question, but this clinical trial does not answer any clinical question. So let's go for it, and I will talk about my point more clearly. It's written here that because of the decreased adhesion of the sealer to the root canal wall, this can be a reason for downgrading the outcome of the root canal treatment, or the interaction of the calcium hydroxide, or let's say the interaction of the remaining calcium hydroxide with zinc oxide eugenol-based sealers, which can form eugenolate and can cause problems with the quality of the seal. So these points can be considered as important factors in decreasing the outcome of, let's say, weakening the outcome of root canal treatment because of these two. But I think if we are supposed to answer these type of questions, we have to have an outcome study, not just a study to evaluate the remaining medicament from the root canal system, because we have more intricate systems, more complex and actually accurate systems in determining the remaining medicaments from the root canal system, like micro CT, like any other in vitro situation that can suffice, can answer our questions. But this question is a clinical question and needs to be answered in an outcome study. And this type of study is not an outcome study. Do you understand what I'm saying? Am I clear to you, Professor Nikufar?
Oh, yeah, I think this is a very important point. I think Professor Sanjay Miglani already confirmed that in the chat box, and he said completely agree. I like to ask other professors to give us their idea about this very important question. So the comment and the question that Hadi tries to set is clinical study should answer an outcome question rather than just such a thing. So let's start by Professor Miglani. Professor Miglani, please.
You know, I completely agree with what the professor was saying. The study is fine because there are a lot of people using calcium hydroxide with the iodoform, but the introduction should have been framed better. You know, the justification given in introduction for the study, I think it is not right. So you can do the study and you can try how to take it out, because a lot of people are using it. But the justification given in introduction does not, suffice the problem. I'm sorry.
Okay. Professor Baber Khan, what do you think about that? What is your idea? Deborah, please unmute yourself.
I think.
Can I say something?
Can you hear me now?
Yes. First, Professor Barbara, and then Professor Farhan. Okay, Barbara, please.
I think calcium hydroxide is still valid in endodontic treatment, because you talk about one session treatment, but the conditions are very important. How can you do one session treatment? If you have a good microscope, for example, I am talking about a necrosis tooth. If you have a good magnification or irrigation or something else, a good nickel titanium files, then you can do it in one session. But if you do not have to give the second chance for the irrigation and the antisepsia of calcium hydroxide, maybe it will be still valid 2 sessions treatment. About this study, maybe they talk about the outcome, and to remove to evaluate the removal of calcium hydroxide from the root canal system, maybe they can use a groove technique. For example, an in vitro study to groove technique can be better in this kind of studies. They can create grooves and put calcium hydroxide, then irrigate or after instrumentation, then they check the grooves and to evaluate what can they see or not. that can be another technique for the evaluation of the removal of calcium hydroxide in these kinds of studies, I think. But for
but the
this study,
question is it really clinically important to remove the remainder of the
that's
calcium
the
hydroxide or not?
dilemma, I think. That's the dilemma, because
Nikupar, can I come in, please?
Yes, please. Yes, we go for that. Yes.
See,
Deborah, you finish and then
what the study they have done is actually very useful, because in this part of world, especially Pakistan, India, Bangladesh, this Metapex or iodoform and calcium hydroxide is used so regularly by the general practitioner. This study is very relevant. It may not be written well, but the study is very good, very well done.
Thank you. But there's a dilemma. For example, if you go and check the American Association of Endodontics about the regeneration side, you can see in the guidelines that there is nothing to remove the calcium hydroxide after applying it. There is no proposal, no. They just put inside the root canal system calcium hydroxide in the first session in regenerative treatments. Then in the second session, they do not talk about how to remove it.
Yes, you're right.
That's the dilemma. In root canal treatment, we try to remove the calcium hydroxide from the root canal systems, but if it is about the regeneration, there is no work how to remove the calcium hydroxide if you use inside the root canal system, if you are doing a regeneration. That's the dilemma, I think. So, so it works. Then I think that if you leave a little calcium hydroxide, I think it will not be very effective in the outcome.
Yeah, but the problem is about the Metapex and the oil-based calcium hydroxide, which the authors in this study try to answer that. Dr. Farhan, please go ahead.
Yes, so what can be done to answer the question? What would be the fate of calcium, of oil-based?
I think
So
Dr.
there are
Farhan,
two solutions to that.
Please repeat your comment because you are disconnected.
Yeah, so there was some call coming that I've just cut down.
Okay,
so
please.
So there are two ways. A, we can design a new study with the research question in mind, that what would be the fate of the residual oil-based calcium hydroxide in the clinic. That's the ideal way to do, is to just design a new study, a clinical study with this research question in mind. And we can, have groups allocation and everything according to that question. What would be the effect of residual calcium hydroxide that is oil-based? So that's one. And a second thing would be, that is more practical, is to have a subset analysis of this study, identify the cases in which it was residual and it was again treated, and then just carry out a follow-up and see what happened, right? So that's the practical way of looking at it.
Very good suggestion. Very good suggestion. I think authors can use that, professors as well. The leaders of this study, they can use those cases and look at the outcome. Amazing suggestion. Professor Bashtur, Professor Fatima Batul Bashtur, please go ahead. Unmute yourself. Yes.
Yep. Sorry, my name appears to be my husband's name on it. So sorry about that. So actually, last year we published a study. As Dr. Baibora said, we actually opened up grooves and filled them with calcium hydroxide, and one of them was an oil-based calcium hydroxide with iodoform. It was called the Calcipast 40. It is like Metapex, but it's from the firm Sarcomet. So we tried to remove it using 3 different techniques, and we couldn't remove the oil-based one with the iodoform. So it was kind of smudged all over the surface, inner surface of the canals. So I think as we are using the bioceramics lately for the root canal obturation, I think the main question should be the interaction of bioceramics with the Metapex or with the iodoform inside the root canals. That was what I wanted to add. Yes.
Yeah, that's good. Thank you very much. So the idea of if the remainder of the calcium hydroxide inside the canal has some effect on other sealers can be a topic of future studies as well. So we already cover a lot of good things so far for the researchers to think about that. And one of the very good suggestions for the leaders of this study in an author's, Professor Ghafoor, is to think about looking at the outcome of the remainder of the root canal system. And also, Dr. Zainab Haji mentioned something in the chat box that we need to concentrate on the question of this study rather than to go to other part that we really need the answer. But the goal of this study not to answer those questions. The goal, as Momina also mentioned, is to look at the remainder of the calcium hydroxide and the techniques that we can remove them from the root canal. But Hadi tries to say that for this question, we don't need actually a clinical trial. Exactly. What we need, as Fatima mentioned, or others, we just need a very simple in vitro study that it can show how to remove calcium hydroxide from the root canal. So
even with more delicate,
better to look at the outcome. The idea is that. So if we go ahead and carry on what Dr. Farhan suggested, that can help a lot. Okay, thank you very much, Hadi. You actually raised a very good question, and I think we all learn from this discussion. But let's ask Professor Ghafoor if she has got any comment about this discussion. Professor Ghafoor.
Yes, everybody is very right, but as I said that it was a very preliminary study done by a junior resident. So she took all the cases that already has been done in the clinic, and then she collected the data for the learning purpose. As Dr. Farhan said, in future, probably that cases can be followed up for the outcome of this remaining basically metapecs in the canal, whether they affect on the outcome or not.
Okay, thank you very much.
I agree with that.
Fantastic. Thank you very much. Thank you very much indeed. Thanks all of you for this discussion. Okay, let's move on, Hadi, because I think there are a lot more things to discuss. Hadi, please.
Yeah, exactly. Yeah. Also, another point to state here was that Metapex, as far as I know, has a radio pacifier in its composition, so which was not mentioned in this study. So if you consider removal of Metapex from the root canal, it may have this fault with it that some parts can be filled with the radio pacifier alone without any remainder of calcium hydroxide itself. So what's your answer to this?
That's a very good point. So that could happen, that we can only get to know about it in vitro studies, but the purpose of this trial was to see the effect in clinical conditions, because the tongue retraction, the saliva, and all the things in presence of a patient and in presence of a tooth in hands is different.
Okay. So in the next paragraph, the authors like to talk about the various methods of analyzing remaining calcium hydroxide medicaments from the root canal system, and the difficulty of removal of calcium hydroxide from the root canal system. They have mentioned that there are several techniques in removing calcium hydroxide: chemical techniques, mechanical techniques, and use of lasers. The most reliable mechanical technique in removal of calcium hydroxide has been considered to be rotary instruments and ultrasonically activated endodontic files, according to the literature. Again, in vitro settings has some limitations, but the authors have decided to remove these limitations, or let's say minimize these limitations by minimizing the factors affecting the results, including the patient's oral health, saliva, tongue, and retraction. To my mind, there is a very big question that are these factors that are named here important in removal of the remnants of calcium hydroxide from the root canal? For example, the oral health or saliva or tongue or retraction procedures?
Why not the use of instruments inside a canal if there is a macroglossia or the retraction is difficult? You cannot take your instruments all the way beyond if you are treating a 7, and you cannot use an ultrasonic file if the person is not cooperative. You can easily remove the medicament, use any sort of instrument if the tooth is in your hands, but and you can take lesser time, but it involves more time, more clinician experience if you have macroglossia, or the retraction is difficult, or the patient is not cooperative, or the access is difficult, especially in maxillary 7. So all these factors, in the end, if it takes time, the clinician might be fatigued that he won't remove all of the medicament if it is taking too long, or if the instrument is difficult to use.
So if you consider all of these factors as confounders of your study, so how did you standardize these confounders? For example, how did you standardize your patient's oral health? Or how did you standardize your patient's saliva and tongue size? You didn't mention any of these things.
We used rubber dam isolation, and we used incisors, canines, and premolars. We did not use molars or multi-rooted tooth for this purpose, so that it is on baseline approximately easier to, in all the patients to use these instruments. So we did not take any 6s or 7s.
So
and
again, you are coming closer to an in vitro situation, right? By removing all of these confounders, you are getting more close to an in vitro situation. So why not an in vitro study?
I don't think so. In vitro results of in vitro cannot be, otherwise we should
exactly.
Probably
but
stop doing trials
you're
if
right.
every study is
You're right.
possible.
But you're removing all of these. You're removing all of these confounders to use and to a situation close to an in vitro situation. So if your patient's oral health is important, so how do you control your patient's oral health? You didn't mention anything about your patient's oral health. Is it a confounder or not? If it is not your confounder, so why you mention it here? If it is your confounder, so how do you control it?
It was only to tell the difference between in vitro and the clinical trial, that what hurdles we could face if we do not do an in vitro study, and what effects it could have, or the difference in results.
Yeah, the thing is, Momina, what we want to know is what is the advantage of a clinical study, an in vivo study, to answer the question of this research. So if you want to answer the question of this research, do you really need this clinical trial or not? That is very important, because you are doing a lot of efforts for this study to make it actually as a clinical trial. But in reality, it is very equal to an in vitro study, but especially by these comments that already Professor Asadian mentioned. So my suggestion is actually we go further now, Hadi, because we already mentioned that times and times. Yeah. And but when we look at the result, I think, and look at the methodology, I think if we just accept this limitation, we can go ahead and carry on and find out anything more useful for that.
All right. So it's written that the literature is unable to propose any single technique that effectively can remove the oil-based calcium hydroxide from the root canal. Because this was not possible in vitro, it warrants a clinical study, which I actually dispute. Well, let's go through the methodology. Of course, the study has a triple blind
Hadi,
design.
Before you go to methodology, I want to ask you for a break, and Zohra is going to show us a video clip from our sponsor, because I think we need a break. We need actually 1 minute break now. Okay, Zohra, please go ahead and show us some of the videos of our sponsor. Okay, Hadi, I think you can carry on because it wasn't ready yet. Okay,
okay.
go please.
All right. Let me just
Carry on, Hadi, please, and then we are going to have our break
go through
later.
the methodology. So the methodology consists of a triple-blind design consort clinical trial on necrotic teeth from July 2019 to March 2020. The inclusion criteria consisted of patients older than 18, single-rooted necrotic teeth, chronic apical periodontitis, which has not been mentioned whether it was symptomatic or asymptomatic. The lesion size was 2 × 2, and canal curvature was less than 25 degrees according to Schneider. Pregnant patients, immunocompromised patients, patients with systemic illness, and periodontally compromised patients also were excluded. And the patient on the teeth which were not possible to be isolated under rubber dam were also excluded from the study. The sample size was determined by sample size calculator to be 42 according to the formula and according to previous studies. And because of the dropouts and to be on the safe side, 60 patients were included and enrolled in the study. Of course, the allocation concealment was performed using sealed envelopes, and the patient and the assessor and the analyst were blinded, and the clinician could not be blinded because of the nature of the operation. So in the first appointment, the chemomechanical preparation was done using sodium hypochlorite, and calcium hydroxide was placed and verified by radiograph and temporarily filled with cavit. In the second appointment, the calcium hydroxide was removed, and the removal was done by any of these methods using rotary or ultrasonic application of endodontic files, and another periapical radiograph was taken after 7 days, and evaluation was done according to a 4-graded scoring system. Here is the 4-graded scoring system. Grades 0 and 1 were effective cleaning, and grades 2 and 3 were ineffective cleaning. And the radiographs were graded for intra-examiner reliability after 1 week using ICC or interclass correlation. The data were analyzed according to the distribution of data, because the distribution of data was not normal. Non-parametric tests like Mann-Whitney U test was used, and chi-square test was used in order to evaluate the effective tooth location on the results. And as I told you, ICC was used to assess the inter-examiner reliability. Let's go through the results.
Hadi, please, before that, there is a comment from Professor Miglani about the sample size. Professor Miglani, please.
Can the authors respond to my query whether this sample size was suggested by a statistician?
Yes, this was calculated by our institute's statistician. The test as well as the sample size.
I think this is not enough. I think we need to justify
what was the power of your study?
Sorry?
What was the power of your sample size?
99%.
I think Dr. Farhan already mentioned something about that. That would be good if Dr. Farhan also tell us something.
Yeah, so let me take just 2 minutes to share this thing. So whenever we calculate sample size,
Dr. Farhan, please try to answer the question that Professor Miglani raised.
Actually, I didn't read his question. So
Okay,
probably his question
Sanjay,
is that the
can you
numbers
repeat
were
the
less.
question, please? Sanjay, can you repeat the question? The question is about the power of the study and the sample size.
Yeah, so there are two different things.
Yeah, Sanjay,
No,
please. Sanjay.
okay,
Farhan,
so
wait a minute.
Let
Please
Farhan
listen to the
complete.
question. Sanjay?
Yeah, I'm here. You know, we do a lot of clinical trials, but this sample size, in my personal opinion, was very less. I don't know who was the statistician, and I don't know how did he calculate such a small sample size for a clinical trial like this.
Okay, Farhan, please.
Okay, so let me share two things. So here, for calculation of sample size, power is one of the parameters. So the investigators here, they calculate 99%, they assume 99% to get a decent sample size, but the mistake that they did, that they divided the number, which should have been multiplied by 2. So whatever sample size is calculated using the sample size calculator, it has to be multiplied by the number of study groups. But here, the capital mistake was they divided the sample size by the number of study groups. So otherwise, the study should have 60 teeth per study group. So that would have given adequate power to the study. In the current form,
Farhan,
this particular study is underpowered.
Dr. Farhan, can I stop you right now and ask Dr. Ghafoor or Momina to answer this? Dr. Ghafoor, the question is, you should actually add up another 60 for each group. So when you calculate it, you should have 60 in each group, total 120 cases, which I think Dr. Miglani also is going to agree with that. But as Dr. Farhan said, you divided this 60 to 2 groups. So in each group, you had 30 patients, which Professor Miglani believes that it is not enough for this study. So it decreased the power of the study. What do you think, Professor Ghafoor?
I think so. Probably the 60 per sample is a better option as opposed to 60 divided into the 2 groups. That gives more power to our study. So that probably a mistake has happened at the time of sample size calculation.
But I think in terms of the sample size calculation, we need more explanation to answer this question. I think when Professor Miglani mentioned that number, it depends on the question of the study. If the question of the study is just about the remainder of the calcium hydroxide inside the canal, Sanjay, I believe this number is not very low. I think it is enough because the question is very small. But if we are looking at the outcome, as Hadi said, if we want to look at the outcome, then we need more cases because number of the co-founder for the outcome is much, much higher when we just looking at the remainder of the calcium hydroxide inside the canal. This is just my opinion. I need actually to calculate the samples myself, but when I look at that, when I say, okay, the question is very narrow, so this number may fulfill the idea for us. This is my comment, but it is very superficial. We need to go deeper. What do you think about my idea?
So can I add a little more thing about sample size calculation?
Please, Farhan. Yes.
Yeah. So regarding sample size calculation, one of the primary requirement is to understand on which basis a sample size is calculated.
Exactly.
Usually it's calculated on the basis of difference in proportion or difference in mean or difference in odds ratio or relative risk. So the second thing, if we are comparing the 2 groups and there are big difference between the 2 groups, for detecting a bigger difference, we need smaller numbers. On the other hand, if a small difference is anticipated, definitely a larger sample size is always needed. So that's the first thing. So the type of difference that the investigators are anticipating. The second thing is the power. Here, 99% power was already taken, but this is a pre-hoc power. There's a difference between a post-hoc power and a pre-hoc power. The post-hoc will be done after the study, And I can assure you, since they have actually divided the N by 2, the post-hoc power would be significantly less. And technically, they're making a beta error here, which means a type 2 error, which in simple words would mean that they could not detect the difference if it existed. So that's my comment.
Yes. So that means we cannot rely on the conclusion easily by this number of cases. Thank you very much.
Absolutely, Nikofar.
Sanjay, please.
Yeah. If we want to find out whether potassium cyanide is dangerous to us, how many samples will we need? Do you want to kill 120 people? No. So it is simple as that. When you are doing a study like this, I think this sample size is absolutely, much lower than what you need. I have been in touch with many statisticians, and they rely on previous studies.
Yes.
And the study they have quoted by Bhuvan et al. Is done in a very remote area of India where you don't get much patients. So I think they could have gone with a bigger size. That's my personal opinion.
Okay.
Can I share a slide?
Yes, please, Momina. Yes, please. Go ahead, Momina. Go ahead.
Okay. Yes. So can you see my screen?
Not yet. Not yet. Yes, now we can see that.
Okay, so these are a few studies that were in vitro. So we had this discussion and this presentation in our institute as well in front of the whole hospital. So these are the sample size numbers of other in vitro studies as well. So ours was not too less according to these other 4 studies. The study by Weissman, Khalil, Puyan, Kumar, all these from 2011 to 2017, they had sample size 46, 45, 24, even 24 and 50. But all of these were done in vitro, but the other studies also have a similar sample size. So maybe we did not think of unnecessarily increasing the sample size for our difference.
Okay, any question? Professor Miglani, Professor Farhan, Professor Asadian, any others? Any comment about this description by Momina, the author?
Yeah, it has a merit. So it means that at least if they had 42 number of observation per group, then probably it would have sufficed. So, but dividing 42 into 21 has actually rendered the study underpowered.
So I think the most important thing is that, yes. Okay, Sanjay?
I agree to Farhan, absolutely, totally.
Okay, I think we already cover the limitation of the sample size in this study as well. And there are 2 more comments. Professor Al-Hawaizi, you have your comment, please. Go ahead.
Well, really, I heard a lot about the efficiency of calcium hydroxide, but what really troubles me is that this research stating that the remnants of calcium hydroxide is between 28 to 35%. Don't you think that this will compromise the obturation protocol? And regarding of another way of disinfecting the root canal, why shouldn't we think of, let's say, for example, photoactivated disinfection? We had a research in Baghdad here, one of my MSc students, and he found very promising results regarding photoactivated disinfection. So why should we consider calcium hydroxide as the only thing that we have really in our clinic?
I think, Professor Al-Hawaizi, what the authors try to say is exactly what you are saying. They want actually to say it is very difficult to remove the oil-based calcium hydroxide from the root canal system. Therefore, your conclusion is in favor of what they show. And this was what Professor Miglani also mentioned, that because in many countries, they still use metapex. somehow as a gold standard of intracanal dressing between appointments, I believe authors try to say that maybe better not to use Methopex, at least, even if you want to use calcium hydroxide. That is the idea. Am I right, Momina and Professor Ghafoor? Do you want to tell us such a thing? Is it the message of your study?
Yes, you're right.
Okay.
You know, you are right, Nikofar. But the way the methodology and the manuscript is written, it is sounds little different. That calcium hydroxide and iodoform works better on Enterococcus faecalis than calcium hydroxide alone. That should have been avoided.
Yeah, that is something in introduction we need to make sure
Study
that
is relevant, absolutely relevant.
Yeah, I do agree with you. We need to speak about the relevant things to our study. That was the one that Hadi also mentioned. Okay, Dr. Suresh, please go ahead. Dr. Suresh, please introduce yourself and carry on.
Yeah, am I audible?
Yes, yes, very well.
Yeah, good afternoon, everyone. I would like to ask the authors, why wasn't any calcium chelator
Dr. Suresh, may I ask you to introduce yourself? Introduce yourself, please.
I'm Dr. Nandini Suresh from India. I'm an endodontist practicing in Chennai. I'm the editor-in-chief of Endodontology Journal, which is the official journal of Indian Endodontic Society, which is the National Forum of India. So that's me.
Yeah, thank you very much for being with us today. Okay, carry on, please. Give us your comment.
Yeah, I would like to ask whether why any calcium chelators like acids, like malic acid, citric acid, was not used or not discussed in this study, because it has been proven that even prior calcium chelators can be used. It's marginally better than in vitro studies in removing calcium hydroxide, particularly with relation to your oil-based calcium hydroxides. Any points on that?
So our objective was to use compare the mechanical methods which are commonly and easily available and used widely in our clinical practice. A number of chemicals and chelators can definitely be used, or a combination of chemical with mechanical method can also be used, but that we have mentioned in our limitation that or further studies that we can use a number of different techniques or different chemicals with mechanical methods or even lasers to check if they are more efficacious than only the rotary or ultrasonic instruments.
Thank you.
Okay, Professor Kayhan, you mentioned something about this oil-based calcium hydroxide as well. Maybe you can add up something to what Dr. Suresh mentioned.
Apart from the discussion about Metapex, people use oil-based calcium hydroxide to apply it better. They think that when they use oil-based calcium hydroxide, they can apply it better. That's the question. That's the question always I am asking to myself. Can I use it? Can I apply it better with Lantulo, or is it by injection? What is the real method? Because if you check the literature, the recent literature says that do not apply calcium hydroxide with injection techniques, because you can extrude the material. And they sometimes propose, Glaskin et al. Proposed, for example, in a recent study, that it will be better to apply the calcium hydroxide with a Lantulo. That's again a dilemma. We don't like Lantulos in endodontics, but at this time, some authors still propose to apply the calcium hydroxide with Lantulos. That's the question. Calcium hydroxide may work, but how do you apply it? Can you really apply it, or you can just in the coronal part of the root canal stem? That's the question, I think.
Okay, I think this is also a very important comment about the way of application of calcium hydroxide and use of the oil-based calcium hydroxide just to make it better for application. But we have a lot of disadvantage of this oil, as we already covered the idea. Yeah, thank you very much, Barbara, for that. I think calcium hydroxide sometimes has use of calcium hydroxide in this way, as you said, in the coronal part, may just have some effect, psychological effect on the endodontist to say that, oh my God, I used something inside the canal. But in reality, it is not going to work at all. Okay, thank you very much. So let's have some video clip from Zohre as a break for 1 minute, and then Hadi is going to share the PowerPoint and try to finish it on time. Okay, thank you very much, Professor Asadian, for giving us the critical appraisal of this very nice article, which is published recently. And we are going now to carry on speaking about the methodology. Okay, Hadi, please.
Okay, the methodology, of course, is over, and now we are going to go through the results. Let me just, okay. A total number of 115 patients were considered eligible to be enrolled in the study, and a number of 55 were excluded because 12 did not fulfill the inclusion criteria. A number of 8 declined to participate, and a number of 5 were excluded from other reasons. Therefore, the remainder, which were a total of 60, were allocated into 2 groups. And after that, the follow-up, of course, the authors had lost to follow-up, a number of 5 for one group and a number of 6 for another. And the analysis was performed finally on 21 patients. Okay. Among the 42 teeth included, 22 were incisors, 13 canines, and 7 premolars. And as I mentioned, the ICC was considered to evaluate the intra-examiner reliability, which showed good reproducibility between the examiners. The results of table 1 shows that there was not any significant difference between 2 groups in removal of calcium hydroxide from coronal, middle, and apical thirds. And table 2, using chi-square test, showed that there was not any significant difference between the tooth location, whether it was in the maxilla or in the mandibular arch, in removal of calcium hydroxide from the root canal. Another important thing to consider was that the medicament was not completely removed in any third of the canal. And the apical part had comparatively greater residue, which was the most important finding of this study. So let's go through the discussion. From the first paragraph, a study by Professor Bolhari was mentioned here that shows the inability of removing calcium hydroxide can jeopardize the push-out bond strength of Resilon epiphany system from the root canal system, and this can be brought about as a reason to perform the study and the importance of and the clinical importance of this study to be performed. There are also some other studies, for example, a study by Khalil, who evaluated sonic and ultrasonic And they found out that sonic and ultrasonic devices can have a better effect in comparison with pro-taper in removal of calcium hydroxide. And also another study by Tamil and co-workers showed that ultrasonic activation was the most effective technique in removal of calcium hydroxide in comparison with rotary. It was shown that rotary systems resulted in 70% residues of calcium hydroxide. So I think the present study, but in the present study, there was no difference between any of the groups. This paragraph tries to show us the discrepancy between the results of different studies, whether any of the mechanical instruments can be superior in removal of calcium hydroxide. So there is a controversial issue, and this cannot be conclusive. And also in the present study, there was no difference. And another paragraph in discussion, the structure of pro-taper has been considered as important in removal of calcium hydroxide. For example, its positive rake, its variable taper, its balanced pitch and helical angle. And it was shown that in a study by Agrawal et al., the rotary files had a better performance in removal of calcium hydroxide. But you know that.
Can I ask you to give us a minute? Professor Miglani, please.
Yeah, I just want to ask the authors, the studies which they have quoted by Khalil and Tamil, were they the normal calcium hydroxide with saline or with the oil?
I think with oil.
So that was with oil as well. Okay, Sanjay. Sanjay, what? Yeah, please.
I'm not sure about that. So, because the study which is quoted by Agarwal et al., I think I am also one of the co-authors. That was not with oil.
Okay, I'll check that.
Yeah, because it is very important to compare the oil-based with water-based or saline-based calcium hydroxide. It has some effect. Okay, also Professor Babara suggests something. Professor Babara, please. Professor Kayahan?
I'm here. I'd like to ask about the irrigation solution. It makes sense, I think. For example, in the removal of calcium hydroxide, they propose to use EDTA. Is there EDTA in this study? I think there's no EDTA, just
no. It's sodium hypochlorite.
Sodium hypochlorite, yeah. I think maybe EDTA can change the game, or that's my opinion, because, for example, most of the studies, I also did a study about the calcium hydroxide removal years ago, and we go up one size, up the final size of the file, and we also use the EDTA. It affects the results, I think. That's my opinion.
Okay. Thank you very much. And also, there is a comment from Professor Sagib that I asked him to talk. Yes, please.
One statement. To remove the calcium hydroxide, did they use a more tapered file? For example, they in the first session they finished with F1, and did they use F2 during the removal of calcium hydroxide? Did they use a larger sized file for the removal? That because it's an important issue. When you check the studies, they say that it's up to one size or three sizes more, and that makes sense also in the removal of calcium hydroxide studies.
Okay,
I don't think so.
Professor Sagib Habib also mentioned something in the chat box, which is confirmed by Professor Iramanesh, about the time of that operator that's used. So he said that we might look into the time taken by operator by two mechanical system, because it also is a variable that may have some effect on the result
Great.
as well. So Fatima, Dr. Fatima Batul Bashturk, please.
As Dr. Baibura said, maybe EDTA might have an effect. However, when we did the study using the calcipost fort, as I mentioned, the one with the silicone oil and iodoform, we used EDTA too. But using sodium hypochlorite in combination with EDTA, using endoactivator, canal brush, or passive ultrasonic irrigation actually did not change the fact that we couldn't remove it.
Yeah, so in that case, I think the idea of using EDTA and sodium hypochlorite rather than calcium hydroxide can be suggested again as well. Okay, thank you very much. Hadi, please.
Yes. Okay. The remnants in the apical part was much more pronounced than other apical than coronal and middle thirds, and this was in line with the other previous studies. And this was attributed to the irregular dentinal tubules and smaller canal area and anatomical complexities and constrictions of the apical third. And also, in addition, the packing force when the files are inserted in the canal for medicament removal. I have a lot of questions here that don't you think that the most important parameter that is important in capability of removal of calcium hydroxide from apical third is because of the poor accessibility that any instrument can have in the apical part, rather than any other things like irregular tubules, smaller area, or complexity, or even the packing force? Do we have any packing force, or we use it passively, or I don't know? Do you use packing forces when you try to remove calcium hydroxide? I need more explanation here.
No, we do not use any packing force specifically, but it can be unintentional force that while inserting the file one can exert. Also, it depends on the taper. If the how tapered is the canal, that it can have access to the apical area, the file can have access to the apical area, also the irrigants. If there is more taper, there is easier access to the apical area. So your reason can be one of the foremost reason that the access in the apical area is difficult, but other causes are also possible, that they can be irregular dentinal tubule, the small canal area, the constrictions of the apical third, and unintentional packing forces while inserting the files.
So you mentioned irregular dentinal tubules. We did not evaluate the penetration of calcium hydroxide inside the tubules. We are just removing from the canal walls. So what does it have to do with the irregularity of dentinal tubules there?
It just gives us the reason why there was more remnant in the apical area. These can be the causes. We did not evaluate these clearing from the dentinal tubules, but these can be factors that it might lead to difference in the results in the coronal and apical area.
I know, but you're justifying.
You need to be very careful when you claim such a thing. You need to be very careful. But it tries to say that you cannot claim something without justification that in your study, because your study was very limited, and these things cannot be easily claimed like that. Okay, Suresh, please.
In this point on where they have asked on the factors that is making it to it's not getting removed from the apical part, I just want to ask the authors whether it's based on silicone oil, so oil, and it's not immiscible in water or any of the liquids, so it's going to be very difficult to remove from the canal. It's a basic fact. And also will it settle down again in the canal? It gets, once you use your ultrasonics, it may get dislodged, but since it's not miscible and it's oil-based, it's going to settle down back, and most it's going to get full or it's going to get packed. Is that what you're trying to say there? The packing force.
Yeah, so you are helping the author, Suraj. Yes, okay. Thank you very much. Thank you very much for your comment. So let's say indirect packing force with that.
Yeah.
Okay, obviously packing force is not correct. So let's move on. Hadi, please.
Yes. Also, it has been written that none of the studies, I mean, in the literature, evaluated the tooth location and its effect on removal of calcium hydroxide. This is the novelty of this publication, or let's say investigation. Also, in this paragraph, the authors would like to discuss about the periapical digital radiographs as a assessment tool because of the low radiation, ease of availability, and because of too many the advantages that this kind of system can bring about for evaluation of the remaining calcium hydroxide. Also, it is written that a large number of studies have used micro CT, CBCT, stereo microscope, or SEM, and they have used extracted teeth in an in vitro session. So we had a lot of discussion about this in vitro design and in comparison with this in vivo design. And so I think that it should be bypassed here. And in another paragraph, the authors try to talk about the limitations of the 2D radiographs because of the superimpositions, magnifications that can have. And this is very important. And this is, I think, a very strong part of the discussion that discusses about the limitations of this evaluation system. And also the missing part is that your use of Metapex, Metapex itself has a radiopacifier in it. So this has not been mentioned, and this is a big lack in this discussion. I think it has to be mentioned. And of course, removal of calcium hydroxide with a radiopacifier has a different story from removal of calcium hydroxide alone. In conclusion, finally, the authors would like to conclude that both systems were equally effective and there was no difference in maxilla and mandible in teeth that were prone to removal of calcium hydroxide. Thank you very much for your attention, and thank you very much.
Thank you very much, Hadi. You did a very, very great job, very clear, very nice, and I really appreciate that. I'm sure others also confirms my idea that you clearly explain the article very well and then appraise that in a very fair way. And thank you very much from authors to stay with us and to accept our invitation. This is the nature of this discussion, to put you in a hot chair. So please accept our apology if we were a bit harsh to you, but it doesn't mean that your valuable article is not going to add up a lot of information to our knowledge. Thank you very much. And so now what we are going to do, we are going actually to put our hand together for Momina Motiwala and show the certification to her. Thank you very much indeed, Momina, for your effort, and we wish you all of the best for your future, and you are going to be the future generation of endodontists in Pakistan and in the world, and we are looking forward to have a lot of more publication from you and your professors under the supervision of your professors. This certificate signed by Professor Kim, the president of the Asian Pacific Endodontic Confederation, that I'm sure APEC is looking forward for having young, wise people like you in it, and Professor Sanjay Miglani, who kindly stay with us to the end of this presentation, and also by Professor Ayati, the Vice Chancellor of Tehran University of Medical Sciences. Thank you very much, Momina, for that. And also the next certificate is for Professor Robia Ghafoor for accepting our invitation and very patiently stay with us. Zohre, please show the next one. Thank you very much, Professor Robia Ghafoor, for leading this very valuable article, and hopefully we are going to have a lot of work with all the participants, all the networks of Asian Pacific Endodontic Confederation. And the last but not the least certificate is going to Professor Hadi Asadian, my friends and my really good friends and good teacher, because he has got actually English course for us in Tehran University of Medical Sciences. We practice our English in advanced level with Hadi, because Hadi is amazing in English. He's also an English teacher as well as an endodontic teacher. Hadi, thank you very much. We put our hand together, and I owe you a lot. Thank you very much indeed.
You always exaggerate about me. Thank you very much for your kind introduction. I'm not at that level, actually. That's very kind of you.
You are. And today,
he
actually,
does that for everybody, actually.
Okay, Professor Miglani, please. We need actually you to talk a little more for ending the session by you and Professor Baber Kayahan. Professor Miglani.
Yeah, thank you very much, Dr. Nikupar. I think it was a very brainstorming session. And in my personal opinion, the question raised by the authors were very genuine. But I think they could have written the manuscript in a different way than what they have written. And I congratulate them. This is a very genuine question which you try to answer. And maybe you can carry on this project further to answer the further question. Thank you so much.
Thank you very much. Professor Baber Kayahan.
Thank you, Professor Nekofar. Thank you for all. I'd like to thank all the participants and the authors for this great scientific night. I think we will meet as soon as possible. Hope to see you as soon as possible. First in Tehran, then hope to see you as soon as possible online. Thank you.
Yes, thank you very much indeed from all of you. Yes, as Professor Baber Kayahan said, we are going to host a lot of endodontists from around the world very soon. So Zohre is going to end up the session by showing you the invitation video clip for our Congress. Hi guys, against all odds, and whatever happened because of the pandemic of COVID-19, we are here for the 20th Congress of Iranian Association of Endodontics. On behalf of our associations, as the president of this Congress, I'm honored to invite all of you to join us to 20th Congress of Iranian Associations of Endodontists, in which we are going to host more than 15 international lecturers as well as 150 national lecturers. We are having a lot of hands-on courses, exhibitions, and a lot of fun attached to our Congress. Join us the last days of September in Iran, Tehran, for the 20th Congress of Iranian Associations of Endodontics. Okay, thank you very much indeed for staying with us for this amazing discussion. Very, very fruitful, very useful. And I'm going actually to end the session by saying that the next session, we are going actually to start our summer holiday for this online journal club. So the next one will be in October, probably, and we will advertise that, and I send you all the information very soon. Thank you very much, and have a very nice evening and night. Good night, everybody. Bye-bye.
Bye-bye. Thank you. Bye-bye.
Thank you very much indeed.